So today I'm speaking to Adam Smith from Adam Smith Podiatry and Healthcare in Prestonpans, just outside Edinburgh. Fungal nails is a topic that comes up over and over again with regards to laser and laser treatment. Adam has been undertaking some research, treating a number of different nails with his MLS laser, and today he's going to share the findings from that. And we're going to discuss how viable the use of laser is for a treatment for that particular problem for fungal nails. So Adam, I'm going to pass over to you and let you do the talking.
Thanks, Kirsten. So we've been undertaking the trial for, well, it must be around about 2 years in between writing it up and everything like that. So now, I'm a podiatrist and graduated in 2009 from QMU in Edinburgh. I've predominantly worked in private practice in recent years. I'd spent a bit of time in the NHS full-time in the community and a good bit of time on the hospital wards. During then, I was looking at things such as wounds predominantly on the ward. I opened my clinic about March 2018, so it's been quite a while. We've got a growing team of 4 full-time podiatrists, 3 part-time, 2 admin, and in I think it's July I'm technically elected on. So July 2020, I was elected on as a member of the council for the Royal College of Podiatry. And here's the lovely Kirsten. She'll introduce herself.
So my name's Kirsten Sinclair. I'm a podiatrist. I graduated from QMU also in 2001. Worked for the NHS for a year before falling pregnant and having my eldest, which then led me into private practice. So I've been qualified for 20 years, most of that time in private practice. I have done some further training, soft tissue mobs, manipulations, really looking to advance more into MSK type treatments. Introduced an MLS laser into my clinic in 2019 and completely changed my practice and has led me to where I am today. So I now work full-time for Celtic SMR as a clinical trainer and offering general customer support and relationship management within that company, and also running webinars with laser users extraordinaire like Adam.
So, as I say, in my clinic, we have used the laser. We've had it since about 2019 as well. I think there were late 2019 we got it. So it was after Kirsten. It's something we've just found so beneficial to our practice. Trying out on the fungal nails was just another addition just to see how useful it was. I cover a little bit towards the end of the presentation about other uses of laser in our clinic if you're interested. So effectively, why did we do this? Okay, so Celtic SMR approached us. They had done a little bit of research internally based on some of the papers which were coming out. There was a paper in 2014 by fellow council member for the college, Ivan Bristol, who pretty much everyone in the country will know. And there's been other ones out which just had a look at the efficiency of lasers on fungal nails. Now, most of the lasers out there work on a 1064 nanometer frequency, while the MLS lasers are a 905 and an 808 multi-locked system. Yeah. So what that means is all of the studies that had kind of went before were using a completely different system, a different wavelength. So it comes up with a different frequency, a different outcome. So by testing the nanometers with the MLS, we got to see just how different it would be compared to the ones which had already been tested on the market. Now, effectively, we were aiming for about 100 participants. We got 116 in total after we'd had a few drop-offs. So 116 people completed the study. So we were above where we wanted to be. What we were looking for as an aim was to check for a negative dermatophyte test after 3 months, also after 6 months, to be honest. So we wanted to see a negative test after one of those, or a clinical improvement at 6 months using the osteomycosis severity index. I'll go into that in a little bit of detail later on, just so you know what that is. As I say, MLS, I think it was ASA, had done their own study on the laser, looking at the effect of the laser on different types of candida.
Yeah, I think.
I can't say that, Kirsten. Fine. And what they found was that putting in around about 200 joules of energy made the fungal cells effectively inert. So it wasn't killing it, it was preventing the spores and the fungal cells from having a chance to multiply and to kind of increase and take over the nail bed in effect. What they found was that the 200 joules made them inert and effectively kind of stops that reproduction. So we had quite a firm inclusion criteria set. So any nail which was going to be tested had to have a positive dermatophyte test. Obviously, it needs to be fungal, basically. There was no contraindications to the MLS laser or any relevant pre-existing medical conditions. For the laser users, you should be aware of that. If you're not, I don't really want to go into all of them. There is quite a few. The main
Contact me, I'll help.
Yeah, the main things are like active cancer in the area, and we just had a look through the exclusion criteria, see if anyone met the criteria to fall in. We chose people between ages of 30 and 75, just to rule out things like children. One of the things you would know if you use the laser is you don't want to use it on growth plates, so we couldn't use it on children who have mycosis. So we thought around about 30 to 75 made a good broad general demographic of the population and covered a high percentage of people who might be interested in it as well. One thing that we also had to ensure was that there was minimal involvement of tinea pedis around the skin. So if you had any active tinea around the nail sulci, we had to deal with that beforehand. So quite often with people, we would enroll them in the study after they'd had maybe a 4-week, terbinafine treatment plus a 30-day period of waiting for that to settle. I'll go into some of these things in a bit. Exclusion criteria was if anyone had had oral terbinafine, just in case it affected the study, they were not allowed to be a part of it for at least 6 months previous. So if somebody came in January and says, I've just had this, literally finished today, we wouldn't have started them until July. So they'd had 6 months for the oral terbinafine released from their system. It might have been interesting to sort of get all of the people who'd had it and say how wonderful things were, but you know what, it's more about making sure the study's as accurate as we can. As I say, they didn't have any other contraindications to the laser. They didn't have any pre-existing medical conditions which could affect the appearance of the nail. These were things such as psoriasis with current nail involvement, atopic dermatitis, or any lichen planus. Anyone who was pregnant was excluded, or anyone who was undertaking cancer treatment at that point. Now, so the laser settings. This is the bit everyone really wants, isn't it? So
Yes.
this is what we done. In effect, it was 150 hertz. We put it onto CPW and 100% intensity. I've put 10 minutes per nail, but that's not. It's 10 minutes per session for 2 feet. So it's 5 minutes per nail. So if you're using any treatment, that would be 5 minutes per nail.
Okay.
We set the automatic treatment because we used the Charlie head. For time-wise, it was found to be a lot better to use the larger devices rather than using the hand probe and having to go nail to nail to nail to nail. The larger device will let you do it in a far smaller time, and it reached that 200 joules of energy per nail much quicker. So practical wise in a clinic, far better to have something like the Charlie head. You can do it with just a handpiece, but it will take longer. So we would, if we had a foot and it was all the nails involved, we would set it across effectively the 2 and 4 nails, because you've got the extra width from the probe head from the M6.
Yeah.
So that would cover if that was moving. And if we were using just a static Charlie head, it would be set just over the second and fourth toes and just moved, just to ensure that we got the right jewels into the right areas. The Charlie head needs to be kept about 20 centimeters away. It's actually got a handy probe if any of you don't have it, so you can keep that sort of 20 centimeters away without having to think about it. The one behind Kirsten, I think if you duck your head, you'll see the probe probably. The wire.
Yes. You can just see it angling towards the back wall there.
Yeah, so that gives you your distance. It's just to make sure you're not too close, not too far away, and it just gives you a good angle for where to stay. And what we'd done was the study only looked at one nail. So let's say Kirsten had came in and had 10 toes, we would just pick one toe and that would be used for the study, and it would be the same toe looked at every time. So we wouldn't be chopping and changing which toe. We made sure right first was the one that was picked, and we would follow that to the letter. So that would be the same toe that goes throughout the whole study in our data collection. So there's a little bit of a patient journey to this. Okay, so we would have a look at either initial contact or recall. So if it was a new patient, we pulled them in. We also went out to a lot of our existing patients. The joys of note-taking systems with electronic, databases.
Yeah.
Fab. So much easier to find
Yeah.
people. So we would discuss the trial with them. Because it was a trial, there was no charge to the patient, just in case anyone's wondering, but no charge for them for that. We went through all the rest, ensured that they fit the criteria that we needed. The dermatophyte test, everyone probably knows the one that we're on about, so that was in clinic. It was chosen because it's really actually quite sensitive. It's got a 98% sensitivity, 78% sort of specificity on different types of dermatophytes, and it's got a really high rate of positive prediction with a quite a low false positives applicable. So that's that's what we chose to use in clinic rather than send away. It just meant we could do things a lot quicker, and we were thinking also about the repeatability of people in clinics. It's nice to send away to a lab, but not everyone's going to want to do that. So we thought repeatability for people in future clinics. The easy use is the 5-minute dermatophyte test that you can do in your own clinic.
Yeah, the whole study was designed to be practical and real life applicable for people in their clinics, and that test kind of fits that criteria, doesn't it?
Yeah. As I said, we wanted to make sure that it was tested kind of as in real world as we can. That's the main thing. So everyone who wanted to do it was asked for their consent, and luckily everyone was quite happy to give it a try. So prior to laser, any other treatment was stopped for 30 days. So if somebody had been using a topical treatment for the nail, had we been doing any fenestration, all of this was stopped for 30 days prior to the study. As I say, the only difference to that was oral medication, which we wanted a 6-month break from. Treatment time frame. So in effect, patients had to be seen 9 times over 3 weeks. Now, ideally, we would have done a Monday, Wednesday, Friday treatment, and then repeat 1 week, repeat another week, and that would have been 3 weeks and 3 blocks. Some people have pointed out that's not always practical, but we did make it work, particularly since it was, if they were getting both feet, they were in and out in about 10 minutes, 15 minutes by the time we documented things. So it wasn't too arduous. We just scheduled end of day, bottom of day, lunchtime, anywhere people could fit in. And generally, most people were okay with that. We never had too many issues. So we tried to get those 9 appointments across 3 weeks. After 3 months, we repeated the dermatophyte. So they completed that block. We would then wait 3 months, and then we would repeat the 5-minute dermatophyte test. The reason for that was we were hoping to see if there was any sort of changing that if there was a negative test, if there was no active dermatophytes within that nail at that point. I'll come on to that in the findings. So we would complete that. If there was a positive test, so they still have active dermatophytes, we would repeat that 3-week block. Quite simple. So 9 appointments in 3 weeks, wait 3 months. If needed, another 9 appointments in 3 weeks. Make sense, Kirsten? Yeah.
Makes sense. Perfect.
Okay. So we taken photos at the beginning and the end of every 3-week block. So when they started, after the 3 weeks, after the 3 months, when they came back for their test, we would do another photo and then another photo at the end, just to see if there was any changes. We used the onychomycosis severity index, as I said, and again, we'll come on to that in just a few minutes. Now, during the treatment, there were a few things. There was no treatment to be undertaken on the nail or skin, just in case it changed things. And the only thing we could really advise was hygiene to prevent infection. As much as we like to follow the latest guidelines on tinea pedis, where you're applying something every month to try and keep on top of it, we didn't want to affect the outcome of the study. Yeah. Now, there's things with that and limitations that the tinea could reinfect the nail, could have had adverse reactions, lots of little things. But we thought at this point in time, we need to just see how effective this is on its own without anything else being involved.
Yeah.
So the only advice we could give patients was on hygiene. So we did advise as many people as we could to move to natural socks, preferably bamboo, about just keeping feet clean, drying between the toes, all of the usual antifungal tinea treatment advice that you would give without recommending any terbinafine or any treatments for the skin in between. So we scored nails basically on day 1. At the end of the block, we were left until they came back after 3 months. And we would then get them back after 6 months just for another check, just to score it and make sure things were kind of where we wanted them to be. We used the OSI. Again, I'll come back onto that. So we followed that throughout. Every time they came in for an appointment, there was an OSI score tribute to. So there wasn't necessarily a change appointment to appointment. Usually by the end of the first 3-week block, there was though. So we'll come on to that.
Okay.
At review appointments, any patients who've been in for routine treatment or we have just had other touch points, we're quite big in clinic of trying to say to people, think of us like the dentist, come to us every 6 months. So when they've came in, we've just done the OSI score chart with the patients and just having a look at how it's changing and what's going on with their onychomycosis at that point. So what the index is, it's quite simple. Everything's numbered. Academics, they like to make things sound as complicated as they can, and actually this isn't. So this is by Caitlin Carney. It was created, Caitlin Carney et al. I'll throw all her friends in there who helped her. So it was created in 2011, and it is actually really simple to use. So what you do is we picked one nail and we would look. Usually we would pick the most affected nail. That way we could gauge the study better. We could see if the results were happening faster and see what changes there were. So we looked at effectively what percentage of the nail bed was affected. So if you had the whole nail and there was only a small corner, but the next one, half the nail was affected, we would pick the one with half the nail because there's more of it. We could get a better score reading. The OSI looks at the infection for VOM all the way down to the matrix. So everything gets ticked and scored and it comes out with a number at the end. So if anyone's got a 0 score, they would have no onychomycosis. 1 to 5 is very mild, 6 to 15 is moderate, 15 to 35 is quite severe. And that's where you have the hyperkeratosis underneath the nail, and usually quite a huge amount of involvement all the way usually to the matrix. A little bit here just shows you where it would be graded to. Just on the left-hand side, got left-hand side of my screen, should be for you as well. So that will show you where it goes down to. So you would, if every section's got a bit of a number on how far down it goes, you would then factor in all of these numbers and you have a score out of 35. There's a few poor factors that need to be sort of considered while using the score, and they're just on the side there. But generally, it was found to be pretty efficient. Everyone in clinic could repeat the study and could repeat the OSI very, very easily. So we had a good baseline and a good way of checking how progress was going. Celtic created a really lovely little chart for us to use. So it was dead simple. We just picked the nail that we were testing, and then on each, you might see my pointer there. Don't know if you can. Can you see the pointer?
Yep, you can see it. Yep.
So you would just pick the nail. Every patient, although we had their details, they were randomized for the study and numbered. And at each touch point, there's a little bit where we just put the OSI in there based on what we've seen at that appointment. And we could just follow this through all the way. When we got to the end, again, Celtic provided us with a lovely little spreadsheet. We could put the score in, and that has allowed us to create our data. This is the most important thing, really. So, for whatever reason, Microsoft likes to make everything the wrong color. So everyone's going to look at that and go, orange is bad. No, orange is good. Orange is good in this, okay? Orange is improved. I don't know why Microsoft done this in spreadsheets, and I could not figure out how to change it. I would have had green for that. But anyway.
We'll let you off.
Exactly. So the green section is your amount which has worsened. So at the far right, you'll see the 31 to 35. Nobody deteriorated in that group. The reason is that group already had the most infected nails. So if there was a deterioration, who knows what would have went on there. But using the OSI, effectively every group improved quite significantly. So you're talking around about a 70% improvement in the least severe group, even up to the most severe group. The only group which, for whatever reason, didn't improve quite as readily as the others were the group with an OSI score of 21 to 30. So they were only about a 60% improvement. But as you can see, every group had a significant improvement of over 60%, which is good. Yeah. The OSI, bear in mind, is more of a visual scale. So visually, your patients were seeing an improvement, which is why they're coming to you. They're wanting an improvement. Very few people remained the same. The highest group was, again, in the 21 to 30. That was at 20% who there was no real visible change within the nail. A small number of them deteriorated as well. So there was some patients who deteriorated. Remember, at this point, we had no other treatment going on, and all this was doing was making the cells inert rather than doing any other treatment. Okay?
Yeah.
So if we look at everything as a whole, 80%, close to 81%, had a number of their nail, had an improvement in the nail that we were looking at, which is very good. I would take 80% that.
80% in healthcare is excellent.
Yeah. So that's good. And considering there was nothing else going on, that's really quite, for me as a clinician, positive. Yeah. There might be some academics out there going, no, but that's fine. I'll take 80% at the minute.
Yeah.
There was only roughly 10% of the candidates had any sort of deterioration, so things got worse. There might have been other reasons. They might not have followed the hygiene advice in between. It could have just not worked for them. But there's always things that need to be studied. But the most important thing for me at the minute is a good number of people seen an improvement of their nails. I'll talk a little bit about the data in a minute. Okay.
Yeah.
these were just a couple of people. So you can see quite marked improvements within the nail coming in from looking like it's been gnawed at to actually looking quite healthy. So again, we had quite a steady improvement with basically everyone who was involved. So it was good. It was quite promising.
And were your patients happy, Adam? Did you get good feedback from them about that?
Yeah, although we've not put it in the study, we did ask them their satisfaction, and what was it? It was around about 76% were satisfied, highly satisfied.
Okay,
so
good.
That's good.
Yeah.
Some people wanted everything fixed straight away, but I've identified a few issues with the study that could improve the results going forward. So, in effect, the MLS didn't prevent a positive dermatophyte reading for 93% of the participants after 3 months. After 6 months, nearly 10% had negative dermatophyte testing. That was almost exclusively in the lower OSI group, so they had a lower number, so they were not as far along in the progression of the mycosis. But that's one part of it. The most important part for me is visually. So the OSI scale showed nearly 70% efficacy and a resolution rate of about 10%. Now that's using nothing else, and at that point, patients weren't even allowed to use an antifungal on their skin. So it's not too bad, for what we were starting off at. So
kind of what we're saying is exactly what you said earlier. It's an inhibition of the infection. It's an improvement of the appearance of the nail, so the integrity and the appearance of the nail, but not necessarily a cure of the actual infection.
Yeah. What we found when we were looking at the OSI scores individually from what we're going to call week 3, and although there's a 3-month gap, week 4, okay? So that 3-month gap just seemed to be too long. So we could get somebody down in the OSI in 3 weeks. Let's call it from 11 to 8 or something like that. But when they came back after 3 months, that's when we were finding they were back at a 9, 10, 11. So although the next round of treatments, the 9 appointments in 3 weeks would improve it again, it just seems a 3-month gap is too long. That's where we were finding that the issue was. So, I mean, we did identify some limitations. It's quite subjective OSI. So while patients are going, it doesn't look perfect and it doesn't look great, and you're going, yeah, but here's the photo from 3 weeks ago. This is how it looks now. So it's subjective. Even the clinicians, some of them would say, oh, is that closer to 25% or is it closer to 30%? So there's always going to be a little bit of inter-practitioner issues just on the scoring chart. The dermatophyte test is effective as it is. There's always the chance that you've had a false positive or a false negative, so just got to include that in there. If people put the Charlie head or the M6 in different positions, that could have affected the amount of joules that went in. Although we did do our training, I just need to make sure that everyone knows that there's always the chance that even if I do it 10 times, you're not going to put it in the exact same spot 10 times. Positioning between appointments for people could change as well. Patients might not have followed the advice that we gave them. That's one of the issues. We had a very small number of dropouts who aren't included in the 116 anyway, but still want to just highlight that. There could be some appointment variations which caused an issue. So it might have been, we did have a couple of people go off on holiday and things, and you're trying to say, well, we did ask you not to, but so instead of all the days in between, it was Monday, Tuesday, Wednesday, we'll see you next week kind of thing. Didn't seem to make much of a negative difference, certainly not on the OSI readings, but that little variance could be something to keep an eye on.
And all of these things are, again, it's real life, it's clinical. This is what we're going to have to deal with in clinic. It's subjective, but it's realistic. So
that's why we wanted to do it as realistic as we can.
Absolutely.
And the main one for me, we weren't treating anything else tinea-wise. There was no other treatments going on.
Mm-hmm.
So, you know, you're allowing the chance for spores to start becoming more alert, more awake and things. So yeah, there's a few issues with, you know, limitations that we've identified, but there's always going to be.
Yeah.
So conclusions. So what we've done with the data is have a look and concluded that it shows improvement as a standalone treatment. I think changing the way the study's done would be better. So we've started experimenting in clinic with people coming in once a week. We've got some people coming in twice a week. We have reduced the gap in between to a month, and we've got some people who at their normal 6-week appointments, we just do it as part of that.
Mm-hmm.
So we're just testing the waters to see what works.
Watch this space.
Exactly. What we've been doing at the minute is, this study was out after we'd completed it in effect. So it was looking at the topical interventions along with it, and it recommends that that's the best way to do it. So you've effectively got the laser making it inert, and it allows your, whether you do fenestration and something such as a turbinifying spray or a clinicept or whatever to permeate under the nail, that seems to be working quite effectively. We've had good results using the laser with M-Trix as well. Mm-hmm. And just heavy debridement, nitric acid. So that's one of our bigger things in clinic at the minute is heavy debridement and a bit of nitric acid on it. So all of these things seem to be working, where if you make the cells inert, you can then start a treatment and you're getting a quicker effect from it, or a better chance of letting that work, shall we say.
Yeah.
So it has encouraged us to shorten the gap between the appointments and prevent the spores from becoming too active in that 3-month period. And as I say, we've just got some ongoing studies from our end just to see how we get on.
Interesting, Adam, really interesting. My main question for you after all of that is, and I have to point out, I haven't actually had the full presentation from you before, so I didn't fully know what you're going to say today. Would you consider using MLS laser to be a viable addition to a clinic for the treatment of fungal nails?
Yes, in conjunction with other treatments.
Yeah, with the topical treatment as well.
Yeah. I'm actually getting not bad results by just doing it on a few people every 6 weeks when they're coming in. So it does inhibit the cell growth to a point. I think just adding a topical treatment seems to work as well, but you're getting more of for us in clinic at this point, more of a result when you are using the MLS laser and a topical. I do find as a standalone, it's actually not too bad, but we'll see what the data looks like when we've been doing just our month break. It is a bit top heavy getting people back 9 times in 3 weeks, but do you know what? If people get the results and they've been annoyed with it for that long, they will come. We've seen that. So
yeah, and patients want to get better. Like that's why they come to you, because they want you to improve their symptoms. And if you can do that more quickly, you know, with laser. And I think so often people, they maybe don't actually care if they've got a fungal infection, they just want that nail to look better. So if you can be using that nail to using the laser to quickly improve the appearance of the nail, whilst you're then treating it with a topical treatment as well, then you're giving them the best chance to achieve what they want to achieve, as long as they're, you know, realistic about it, and you're explaining to them this is not a cure on its own, but
yeah, it's like all patient expectations. They just need to be managed, and these are the real world scenarios. These are what's happening. This is where we can get you, but there's always that caveat of it might not get there quickly, or it could take time. But just managing patient expectations. Yeah.
Interesting, Adam. We'll just wait and see what you come up with your topical treatments combined with laser. We'll have you back for another webinar once you've gone through those. Okay. And actually, just in addition to that, so leading up to this webinar, you know, I've been looking at some papers myself, And it seems that, I know you touched upon generally lasers used for fungal nail infections are about that 1064 nanometer wavelength. And most of the studies, if not all of the studies that I looked at using that wavelength, had the same conclusion. It's an inhibition, it's not a cure. It improves the appearance and the amount of clear nail that you can see, but it doesn't cure the infection. So again, you need to use it combined with a topical treatment. So just interesting that it is comparable, the 808 and the 905, the ultimate effect of that is comparable to the effects of the 1064 nanometer lasers as well.
Yeah, we found that throughout looking at people who've looked at randomized studies. I mean, I've got a whole load of resources there. There's some that I just haven't added because they were last minute additions we're looking for and things. But, we looked at it, and the same, it doesn't matter what kind of laser or what type of laser people are looking at, the same conclusions coming up from the researchers. It improves things in around about, I think the average is around about something like 70%. So we're hitting that. And yeah, just it really needs something else. So the thing is longer term as well. I mean, if it's cured, you've got to rely on the patient to keep it that way, keep it under control of it. So there's a few things, but it's positive. I like the data. I think that's very encouraging.
Yes, I agree. And did you have some slides to do with your general use of the laser as well, if people want to hang on and listen to that, Adam?
Yeah, just in case anyone doesn't have the laser. So yeah. As far as I'm aware, this is the only laser with this multi-locked 2 frequencies.
Yeah, I think you're right. Yeah.
Yeah. So it's a unique selling point to the ASA laser and Celtic SMR that it does do, it does things that the others can't because it's got this 2 nanometer frequency. Yeah. So our whole team in clinic use it. The only one not on
so
there
they do.
The only one not on there is Helen, because photo day is next week, so she'll get a photo added then. But we all use it. It's not too complex to actually get to grips with. So if you don't have the laser, definitely give it a trial. That would be my
and just to point out that if you do take the laser on as a trial, or if you have a laser and you take on a new associate, a new clinician, then we'll do full training for the trial, or we'll also provide full training for your associate, and that's all completely free of charge.
Yeah. Big thing for us was the addition of we added the Charlie head first, which is the robotic head for the sort of handheld system. And we've also went to the M6, which is the autonomous robots that can kind of just move around and do things while you go off and edit an orthotic or, sort an exercise plan while somebody's there. For the fungal nail, both invaluable because it cut your treatment time really quite markedly. For us, when we're doing things like MSK, it's just so handy if somebody comes in with plantar fasciitis, you can do use the handpiece on the plantar fascia, and you can do a little bit of work on muscle contraction or tendinopathy on the Achilles, or trying to release the Achilles, or possibly you found an issue at the perineal that you're trying to, just solve a little bit. So you can do multiple things. Being able to treat multiple areas is a huge selling point, as well as the fact that it reduces your treatment time. So in clinic, if you don't have the Charlie head or the M6 or something along those lines, definitely have a look at it. It's well worth the investment.
I agree. Yeah. I'm just going to say that all the time with you, Adam. I agree. I do.
So, I mean, yeah, a lot of people are going to think it's just for MSK, but it's not. And I know some pods don't like MSK, so I always try and sort of put things in that are all MSK related.
Yeah.
The big thing for us has been wound healing. I started using it for wound healing very quickly. So the slide on the left, you can see basically it was a patient who appeared to us. She had around about 4 weeks of GP and nurse intervention, which had left the foot looking like that. We've done 6 weeks of just dressings and hugely improved it, but it wasn't closing. So we then moved on to the laser, which handily arrived around that point. And within 6 weeks, you can see it had totally closed. It just became very stagnant. Although we'd done antibiotics, we'd dressed it, we'd offloaded, we'd done everything we were meant to, it just wouldn't close after 6 weeks. And it was improving, but it was just going to take a while. So that was really good. We've managed to reduce our nail surgery dressing times by around about 2 weeks. Private practitioners, time is money. If you can reduce these things, it helps, you know. But this is something I keep talking about this to Kirsten, and it's you know, it's only been about a year we've been talking about me writing this up.
You'll get there. This is progress.
It's progress. It's actually written down somewhere. I had a 65-year-old female who presented with a caliper using 2 walking sticks. She had pain and neuropathy all down her right leg, caused by mononeuritis multiplex. Now, that had been diagnosed externally. She had been pillar to post, and we were kind of her last kind of option, I think. She'd been at the pain clinic, she'd been everywhere. So she came in, and in 7 appointments over the course of 4 months, we got her down to using no caliper or walking aids, and we literally just used the laser. So
incredible. Really, it's such a huge life-changing difference for that patient.
Yeah. It was that, you know, we started adding some rehab things in. So I'll say nothing else. I mean, nothing like, I wasn't even doing soft tissue work or acupuncture at that point on her or anything. It was just, let's get some laser in here and start trying to improve the neuropathy. And 4 months, no calipers, no walking aids. She was delighted.
Awesome. Good work.
And last one, just because it's my favorite photo of Jill ever, and she knows
Does she hate it?
So yeah, MSK is a huge use of it. You've got such a range when it comes to the laser. So conditions such as hematomas, if somebody's had quite a new injury, or just trauma. Tendinopathy is a big one. Achilles tendinopathy, plantar fasciitis type pain. What's around the knee? So we've had quite a bit of sort of patellar tendinopathy recently. If they've been overexerting quads, or people just going gung ho at the gym.
Yeah.
Lots of muscle tears. We've had lots of good result with them over the years. It does work quite well on contraction. Not so much something like Dupuytren's, but I mean, bar surgery, you're talking, not a lot's going to help there. But if somebody's really tight and you're struggling to just get that heel on the ground, if it's an Achilles, or they've got a contraction, a hamstring because of something, we're finding just the laser's really good at just loosening that up.
Yeah.
And as I say, good bit of pain reduction with arthritis as well. So we found it probably the single most beneficial thing to the clinic, bar the staff and the team. It's a bit of a one-stop shop for so many things. We can use it on patients, and there's a reason we have to put it that way. We use it all the time.
Yeah, well, that's great to hear. A really good overview of laser for fungal nail, and then a nice little add-on at the end there for other indications for use as well, Adam. Thank you so much.
That's all right.
It's been a pleasure to talk to you today, and I'm sure you're always super helpful, Adam, and if anybody did have any questions that they'd like answered, they could pop them in the Facebook group, the Laser Forum healthcare group on Facebook, if they're in there. If not, find it and add yourself in. We'll add you. Adam's in there. He'll see your question and answer it for you. Or you can email me. It'sksinclair@celticsmr.co.uk, and I can forward your inquiries to Adam from there. Thank you, Adam.